There's a sleep crisis happening in plain sight, and for decades we have mislabeled it as just aging. Women in perimenopause and menopause are showing up exhausted, frustrated, and often dismissed. They are told it's just stress, or anxiety, or poor sleep hygiene, or that insomnia is just part of getting older. And then they are handed a prescription for a traditional sleep medication that works briefly, poorly, or not at all. What's actually happening is something much more specific. This is the menopause sleep gap, and it's one of the most underserved and misunderstood areas in clinical care today. But clinicians are finally recognizing what patients have been saying for years. Menopausal insomnia is not the same as primary insomnia. It is not just trouble falling asleep. It is not just racing thoughts. And it's not fixed by sedating the brain. It is a hormone-driven sleep disruption. And until we treat it that way, we are going to keep failing these patients. So today, we're going to unpack what's really happening with estrogen, progesterone, and sleep regulation, and how to distinguish primary insomnia from hormone-driven sleep disturbance in midlife women. Many women in perimenopause don't complain about difficulty falling asleep. They fall asleep just fine. The problem is what happens next. They wake up at 1, 2, or 3 in the morning, often suddenly, sometimes hot, sometimes anxious, sometimes with a pounding heart, sometimes with no clear trigger at all. And once they're awake, they are awake. The sleep drive is gone. Sedatives may make them drowsy, but they don't restore restorative sleep. That pattern, sleep onset intact, sleep maintenance disrupted, is a major clinical clue. Now let's talk hormones. Estrogen plays a significant role in sleep regulation. It modulates serotonin, GABA, and melatonin signaling. It also influences thermoregulation. As estrogen levels fluctuate and decline during perimenopause and menopause, the brain becomes less stable in its ability to maintain sleep. Small internal or external stimuli are more likely to trigger awakenings. Progesterone is just as important and often overlooked. Progesterone has GABAergic properties. It's naturally calming. It supports sleep, continuity, and reduces nighttime arousal. As progesterone declines, women lose one of their built-in sleep stabilizers. So when estrogen and progesterone drop or fluctuate unpredictably, the brain becomes more vulnerable to nighttime awakenings, autonomic surges, and fragmented sleep. This is not a failure of willpower. It is not anxiety masquerading as insomnia. And it's not something you can CBTI your way out of if the hormonal foundation is not addressed. Here's where traditional sleep medications often fail. Most standard sleep medications, whether we're talking about Z-hypnotics, sedating antidepressants, or off-label agents, are designed to increase sedation or suppress wakefulness. They don't correct thermoregulatory instability. They don't restore progesterone's calming effect, and they don't stabilize estrogen-sensitive neurotransmitter systems. So patients say things like, I feel drugged, but still awake, or I wake up anyway, or I'm sleeping, but I don't feel rested. So let's challenge a common assumption. Many clinicians assume that if a menopausal patient has insomnia, the correct first move is to treat it like any other insomnia. Sleep hygiene, CBTI, a hypnotic if needed. That assumption skips a critical diagnostic step, asking whether the insomnia is primary or hormone-driven. Primary insomnia usually has a longer course. It often predates menopause. It is characterized by difficulty initiating sleep, conditioned arousal, and cognitive hypervigilance. These patients often say, I have always been a bad sleeper. Hormone-driven sleep disruption is different. It often begins in the early to mid-40s. It coincides with cycle changes, hot flashes, night sweats, mood lability, or new anxiety. The insomnia feels sudden, new, and out of character. These patients say, I used to sleep fine, and then something changed. That distinction matters. Because when sleep disruption is hormone driven, sedatives alone are treating the symptom, not the cause. This is where hormone therapy enters the conversation, and it deserves a more nuanced discussion than it often gets. In 2026, the clinical consensus has moved away from just wait it out toward targeted multimodal interventions. For appropriately selected patients, estrogen replacement can significantly improve sleep continuity by stabilizing thermoregulation and neurotransmitter signaling. Progesterone, particularly micronized progesterone, can directly improve sleep quality through its calming GABA modulating effects. Micronized progesterone is not the same as the older synthetic progestins. It is neuroactive. It metabolizes into allopregnanolone, which acts on GABA receptors in the brain. In practical terms, it stabilizes sleep rather than simply sedating the brain, helping many women stay asleep instead of waking up wired in the middle of the night. Estradiol is other major piece. Transdermal estradiol, patches or gels, is generally preferred over oral forms because it bypasses the liver and carries a lower clotting risk. From a sleep perspective, its biggest impact is thermoregulation. By reducing night sweats and hot flashes, it prevents abrupt awakenings that can fragment sleep. Used correctly, hormone therapy does not knock people out. It restores sleep architecture. That said, hormones are not for everyone. And this is where one of the biggest shifts in recent years comes in. For patients who cannot or choose not to take hormones, there has been a major breakthrough in non hormonal treatments that target the brain circuits responsible for hot flashes. These medications act on KND neurons in the hypothalamus, the neurons that drive thermoregulatory instability after menopause. These neurons co-express and release three key neuropeptides: kisspeptin, neurokinin B or NKB, and dynorphin. Fezolinetant or Veoza, an NK3 antagonist, is already FDA approved and reduces hot flashes without using estrogen. Newer dual acting agents such as elinzanetant or Lincoet target both NK1 and NK3 receptors and appear to improve sleep quality itself, not just hot flashes. It is not approved in the USA, though. Now, this changes the narrative. Avoiding hormones no longer means accepting poor sleep as a trade off. Behavioral treatment has also evolved. CBTI remains effective for primary insomnia, but menopausal sleep disruption requires a different approach. CBTMI, this is cognitive behavioral therapy for menopausal insomnia, addresses not just sleep habits, but temperature anxiety. That is the panic, frustration, and autonomic surge that happens when a hot flash starts at night and keeps the brain awake long after the flash ends. Learning to interrupt that cycle often determines whether someone falls back asleep or stays awake for hours. The best outcomes come from combining physiologic stabilization with sleep-specific behavioral tools. Okay, now let's talk strategy, because this is where care often stalls. Patients should be asking, if we start treatment, how long should it take to improve my sleep? And if it doesn't work, what's the next step? If sleep does not improve within about 4 weeks of appropriate treatment, whether hormonal, non-hormonal, or behavioral, the plan needs to escalate. And here's the critical provider reminder. Obstructive sleep apnea risk increases significantly after menopause. Estrogen helps maintain airway tissue tone. As estrogen declines, airway collapsibility increases. If hormone targeted treatment and CBT-MI fail, the next step should be a sleep study, often a home sleep study, not another sedative. Too many menopausal women are walking around with undiagnosed sleep apnea, misattributed to anxiety or aging, while accumulating medications that never fix the real problem. Now, let's zoom out to the bigger picture. There is a massive underserved population of perimenopausal and menopausal women who are desperate for answers. They are educated, they are vocal, they are comparing notes, and they are increasingly dissatisfied with being told that insomnia is just part of aging. Clinics that understand the menopause sleep gap are not just improving outcomes, they are differentiating themselves. And here's the uncomfortable truth. If clinicians don't learn how to distinguish hormone driven sleep disruption from primary insomnia, patients will find someone else who will. So let's bring this home. If a midlife woman presents with new onset insomnia, especially sleep maintenance insomnia, ask about menstrual changes, hot flashes, night sweats, and mood shifts. Don't skip the hormone context. If traditional sleep meds are failing or only partially helping, don't assume the patient is resistant or anxious. Consider whether the underlying driver is hormonal instability. And if you're not trained in menopause management, collaborate, refer, build a network, because this is no longer optional knowledge. It is standard of care catching up to reality. The midnight awakening is not a mystery. It is a signal. And when we stop treating menopausal insomnia like generic insomnia, we stop blaming patients for biology and start delivering care that actually works. Okay, that's a wrap for today. Thanks for listening. And if you found this episode useful, share it with colleagues across disciplines. Until next time.